Hi, I'm Dr. Harvey Sarnat, and this is a full-term twin, dizygotic twin girl infant who has a fracture of the left humerus from difficult delivery and had some depression after birth, required even intubation for 4 days, but is doing much better now. And in the neurologic examination, I'm going to start, sometimes we have to do things a little bit out of the usual order to take advantage of the infant's state. And so since the infant is calm now, we'll do some things that would not be very easy to be able to assess if the infant is irritable or crying. So one of the first things we do is the first cranial nerve, and that's the olfaction. And you have to use a test substance, which is not an irritant that would stimulate pain endings of the trigeminal nerve that also live in the nose. So you need a pure aromatic substance, and peppermint extract is the one that I've used traditionally, and that other people have. Cinnamon, there's a number of different things. Cloves could be used. You would not want to use a test substance such as ammonia or alcohol because it's an irritant as well as having an odor, and it would mix the two stimuli. So we want to see how the baby will respond to olfactory stimulus. The baby does have a nasogastric tube in, which obstructs a little bit of the airway, but not too much. And this baby is not having a lot of response now. A baby who's deeply asleep may not respond. And we can try this again later when the baby's a little more awake, because she is sleeping actually. The response, the olfactory reflex that we're looking for is about 2/3 of these babies will start to suck with peppermint, and the other third will show some element of arousal withdrawal. They will retract their head, or they'll rub their arm across their nose, or they'll even just wrinkle up their nose with a facial grimace to indicate that they've perceived the olfactory stimulus. So this is the sort of test that sometimes you have to come back to over and over again before you can be absolutely certain. But it's an important test because it can be depressed in conditions of hypoxic encephalopathy, for example, and metabolic diseases. And you also have absence of the olfactory bulbs in a number of different malformations. Holoprosencephaly is sort of the most known malformation, but also in some cases of septo-optic dysplasia and in many other malformations. And even without major malformations, there's other syndromes such as Kallmann syndrome in which the olfactory bulbs may be absent. So it's important to do. We'll try it one more time and then we'll go on to something else. Well, she is reacting. Well, she's yawning. So that's not quite the response I was hoping for, but there. See that mouthing, the lip smacking with the peppermint? So I would consider that to be a positive reaction. And again, as I say, this is the sort of thing you can go back and repeat over and over several times to be absolutely certain. And then with MRI and a coronal cut through the posterior part of the orbit, you can see the olfactory bulbs quite well. And if they're absent, then you don't see them, but they're a very distinctive feature. In examining the baby, we want to first of all look at, we have to take some of the covers off so that we can actually see the baby and be able to detect things. I think this will be enough. And so what you want to do is you want to first of all inspect the baby in terms of several features. One is whether the baby has any obvious external malformations of the extremities, of the face, facial dysmorphism, hypo or hypertelorism, for example, whether there are two nares in the nose, nostrils, whether there's any asymmetry and the shape of the head, and whether the head looks grossly enlarged or small. And you would want to measure the head circumference to document the actual size. Other things you would look for in external examination would be you would want to examine the skin to see if there are any nevi or obvious cutaneous lesions that might denote some type of neurocutaneous disorder, such as epidermal nevus syndrome. And you want to look also in the face, especially, to see if there's a midline nevus that's starting at the tip of the nose and going up onto the forehead and onto the scalp, and looking for hemangiomas. I'm not going to roll the baby over because of the fracture of the arm, but you would want to look at the lower spine to see if there's a pilonidal dimple or a tuft of hair or some other indication that there may be a neural tube defect that might be more severe internally than is apparent externally, and would indicate that you should do some imaging to detect that. And you want to look at the baby's posture and movements. Is the baby showing spontaneous movement? Are those movements symmetrical? Do they involve both the upper and lower extremities? And what is the posture that the baby is assuming at rest? For example, the frog posture with the hips widely abducted would suggest that there's muscular hypotonia, and we'll talk about how we would examine that more objectively in a minute, but that would be one thing we'd look for. Are the arms extended or are they flexed at the elbows? In this case, of course, there's some restriction here because of the fracture, so the baby is tethered a little bit in that left arm, but so the symmetry is a little more difficult to detect. Is there arching of the back, like opisthotonus, for example, which would indicate a very important corticospinal tract lesion. And you want to look at the hands and the feet to see what the postures distally are as well. Is there strong flexion of the toes, or is there spontaneous extension of the toes? And in the hands, you want to see whether there is adduction of the thumb and flexion of the fingers over the thumb, and sometimes flexion of the wrist as well, which would indicate again, corticospinal lesion. There's good physiological explanation for these postures, but those are the things you would want to look at. And while you're looking at the posture of the hand, you can see that this baby spontaneously opens the hand, extends the fingers, which is good. And maybe I'm getting ahead of, but there is a little bit of adduction of the thumb. If you notice, the thumb is a little bit across the palm instead of being extended. If you do dorsal stroking of the fingers, there should be extension. This is an important tactile reflex. We can see there's extension on both sides, even on the side that is immobilized for the fracture. We want to look at also whether there's any spontaneous clonus, jitteriness, which is really clonus. It's again a corticospinal sign, really. And here we can see that there's a little bit of jitteriness at the knee, and I was noticing in the hand as I was talking, and so this is a little bit of an exaggerated reflex from lack of sufficient inhibition, because there's a balance between some of the bulbospinal pathways and the corticospinal tract, which is mainly inhibitory, and and suppresses the stretch reflex, which, if not inhibited, will cause several beats of clonus, basically. And so that's the other observation that we want to make. Now, the other important observation is, how is the baby breathing? Is the baby breathing normally? Is he having difficulty with respiration? If there's difficulty, is it something that can be explained on the basis of peripheral mechanical or anatomical features, such as airway obstruction, or perhaps pulmonary lesions that are causing difficult respiration? Or is there difficulty in respiration because of central control of respiration? There are several brainstem centers that regulate that. The nucleus solitarius is the most important, the pre-Potzinger nucleus, and there's some other centers in the brainstem involved as well. We want to look at the pupils to see whether there is meiosis, a very tiny pinpoint pupil, or whether there's mydriasis, or a dilated pupil, which will tell you something about the autonomic function, whether there's mainly a sympathetic or parasympathetic discharge. And the autonomic nervous system is important to determine in a baby, especially a baby who's had an insult such as hypoxic episode during delivery or at birth. And there's other features of the autonomic nervous system that also will give you some indications. One would be the heart rate. If there's an excessive bradycardia, that would be increased vagal stimulation, parasympathetic overlay over the sympathetic. Usually that might be associated with increased peristalsis from the vagal nerve, and so the baby might actually have a lot of bowel movements that you can see in the abdomen, and you would hear those excessive bowel sounds if you used a stethoscope to auscultate it. And the baby may even have diarrhea or watery stools because of the increased peristalsis and rapid passage of intestinal contents. The color of the baby and the mottling of the skin would give you an indication about the autonomic vasomotor effects cutaneously, and that may reflect some of the effects in the brain as well. Before we leave the external examination, the other thing that you want to always examine is the fontanelle. And you want to feel whether the fontanelle is normal and soft, and it should be a little bit pulsatile, and or whether it's bulging and tense, which is abnormal. And you would want to measure this fontanelle. Looks like it's about 3 to 4 centimeters in the horizontal axis, and maybe 3 centimeters in the sagittal plane. I would have to use a tape measure to quantitate that, and during a normal examination that's what we would do, and the posterior fontanelle as well. And certainly a tense fontanelle would be something of concern, and you would want to correlate that with a head circumference, because the baby may have an obstructive hydrocephalus, either from a malformation such as aqueductal stenosis, or from an acquired event such as intraventricular hemorrhage that would obstruct the passage of CSF through the normal pathways. Or there may be some other lesion that is causing increased pressure, such as a subdural hematoma, or rarely a congenital tumor of the brain or something of that nature. This baby doesn't have any indication for any of these things. The fontanelle is quite soft and normal in palpation, and the size is quite appropriate for for a full-term baby. There's a lot of variation in normal size of the fontanelle, but this is well within the normal range. Now, in further examining a baby, we would want to look at muscle tone. And muscle tone is distinct from muscle strength. So muscle tone is basically in the extremities. We're talking about range of motion around a joint. You may be hypotonic, for example, and weak, or hypotonic and strong. So you should separate the two. And it's much more frequent in newborns to have hypotonia, even though they may later develop hypertonia as they get older after several months. But hypotonia is more frequent. Hypertonia is much less common in the newborn and usually is associated with certain distinctive disorders, such as a subarachnoid hemorrhage, for example, would be one cause. Hypercalcemia might be another cause of hypertonia in the newborn. But if you do find that, then that's of concern. And the way we want to look at the muscle tone is range of motion. And in the lower extremities, you would look at both distal and proximal. So distally, well, we'll start proximally. What you want to see is range of motion around the hip. And we do this in two positions. We do it with the hip adducted, and we extend the knee and see how far can we extend the heel. Yeah, there's a tube here. That's okay. And we can extend this heel up to the umbilicus. That is normal. Then we do it with the hip abducted, rotating the hip carefully without hurting the baby. And we do the same thing, and we can see that we can get up to the umbilicus. And on this side, the tubing here, but that's okay. We can match that. We can see that we're okay. I'm not going to break any of the tubing. So this is the same. It's symmetrical, and with the hip abducted, you can see we can go to the umbilicus. If the heel goes above the umbilicus, if it gets to the nipple line, this would be considered mild hypotonia. If you can rotate it all the way that the heel touches the ear, this is severe hypotonia. If, by contrast, the hip rotates only so the heel gets to the pubic symphysis and doesn't even reach the umbilicus, that is hypertonia. And that may be due to a mechanical problem in the hip, if there's a contracture of the hip for some reason orthopedically, or it may be increased muscle tone. And so those are the ways you would quantitatively measure muscle tone in the lower extremity, in the proximal. Now, as far as the distal extremity, in the lower extremity, you would want to dorsiflex the ankle. And you can see that in a newborn, you can touch the dorsal part of the foot to the pretibial surface, which is normal in a newborn. It wouldn't be in a 6-month-old, but it is in a newborn. And we're doing this with the knee at 90 degrees because we are testing the soleus muscle alone without the gastrocnemius, because the two heads of the gastrocnemius insert on the epicondyles of the femur. And so knee position makes a great difference in the stretch of the gastroc muscle, whereas the soleus muscle inserts on the tibial tuberosity entirely below the knee, and knee position makes no difference for the. So that was the soleus muscle. And now, if we extend the knee gently, we now dorsiflex the foot again, and we can do the same thing. And now we're testing gastroc and soleus muscle together. There's no way to really test the gastroc by itself because the soleus is always there for. But you can separate the two in that way. So distal hypotonia is a little difficult to diagnose in a newborn because all newborns are a little bit hypotonic physiologically and distally, but nevertheless, This is something you'd want to watch. And of course, you always want to look at symmetry in the two sides, because an asymmetry is always abnormal. For the upper extremity, and this is going to be more difficult because I can't test the other side, for proximally, for the shoulder, and I'm going to do this in a limited way because I don't want to hurt the baby, you bring the arm across the chest, and you should be able to get to the midline, to the sternum, and maybe a little bit beyond it, and that's normal. If you can bring the elbow all the way across to the shoulder, this is hypotonia of the upper extremity. And then we want to look distally, and the way we can do that is to dorsiflex the hand, and you can see that this is not excessive. Excessive would be if you can make two 90-degree angles to make a little box. So you have a 90-degree angle at the wrist and another 90-degree angle at the metacarpophalangeal joint where the fingers join the hand. And if you can make a little square box like that easily without forcing it, then this is considered distal hypotonia. There's many other maneuvers you can use. Abduction of the thumb, for example. If you can bring the thumb all the way down to touch the radial surface of the forearm, then that would be hypotonia. This baby is not hypotonic and cannot do that, and that's good. That's normal. For axial tone, what you want to look at is mainly head lag. And I can't do this in this baby because the baby has a fracture and I don't want to make that worse. But the way you would test that with the baby lying supine like this, you try to pull the baby up to a sitting position with the arms, both arms, and see if the head leads. The head usually falls back a little bit, and then he has enough head control that he comes forward, or she comes forward with her head. If the head just simply flops back with absolutely no control at all, then that would be hypotonia of the axial muscles, unless the head is excessively heavy. If you've got a child with hydrocephalus or a large head, which weighs more than the normal head, then of course the muscles are being asked to do a lot more work to lift against gravity, a larger weight, and so that you have to take that into account, that there may be other factors that contribute to head lag besides simply muscle tone. And while you're doing the test for head lag, and again we can't do this in the baby very easily, is you want to look at the Moro reflex. There's a number of ways of testing that. The best way is to go under the baby. I don't want to do this in this baby, but hold your hand under the upper part of the back and your left hand supporting the head, and then just let the head drop back a little bit, and normally the baby will have the extension of the arms and fingers, and then retraction, then flexion, and usually followed by a slight cry, which does not mean pain. It just is part of the reflex. It's a reflexive cry. I saw this baby when we were manipulating the baby a little bit have several spontaneous Moro reflexes, which is common, and so I think the Moro reflex is intact. You can see a little bit of clonus here, and babies who have clonus will have a more hyperactive Moro reflex, and it'll be elicited more easily than usually one would elicit that. Now, looking at the other cranial nerves, we looked at the first nerve. Babies at this age don't fixate very well, but sometimes full-term newborns, especially if they're 40 weeks or more, they will have brief fixation. And then if they do, you want to see if the eyes are moving conjugately, if they are fixating on something. And if the baby is actually fixating, you can use optokinetic nystagmus as a means of determining visual fields. this baby is having very brief visual fixation as I was watching her, but not for very long. And what you want to do is try to get her to fixate on the striped cloth or drum or whatever that you're using, and see if you get. Now she's closed her eyes. She does have one or two beats actually. She does have one or two beats, and she has it in both directions in the horizontal plane. You can do it even in the vertical plane. I'll get to that. You can do it in the vertical plane as well if she'll open her eyes for us. There you go, honey. Yes. And so she has optokinetic nystagmus, which means she has full visual fields. If she had a hemianopia from an occipital lobe lesion on the other side or some other reason, then she would have asymmetrical optokinetic nystagmus. Usually it would be apparent from one side but not from the other. As she gets older, this will be easier to determine. The key ingredient for this test is the baby has to be able to fixate. So a small premature infant, you can't really use this because they were unable to fixate, and therefore you can't really interpret the test. We can try olfaction again. We can try this several times during the exam to confirm. Well, it's difficult to interpret whether that was spontaneous or. I think she did suck a little bit, and I think that that is positive. Now we also want to test the tendon reflexes in the baby, and this baby almost certainly is going to have very brisk reflexes because she already has clonus, and so that tells us that the reflexes are a bit hyperactive, and so I would expect them to be quite brisk. In a baby who has hypotonia, the reflexes may be reduced because the strength of the stimulus you're delivering is less. Now with the knee jerks, not only do you want to look at whether the leg is reacting, but you also want to look if there's cross deduction of the other leg, the adductor magnus muscle of the other leg, because that's spread of the reflex through the pelvis bones. They aren't as active as I thought they would be, but they're present. And the other good reflex to test in newborns is the brachioradialis, which is usually pretty thin. She has a good brachioradialis reflex. The biceps brachii and triceps brachii are sometimes a little more difficult to elicit in a newborn, but the brachioradialis is a C5, C6 innervated muscle, and it's usually quite easy to test. She appears to have a little bit of facial asymmetry when she yawns or smiles, not retracting the right side quite as well as the left. It may be that she had, you see, the corner of the mouth, is more depressed on the left side than it is on the right side, and so it may be that on the right side that she had a little bit of compression of the facial nerve during delivery. We know she had some difficulties with the delivery because she even has a fracture of the humerus, but she may have had a little bit of facial nerve compression as well, and that's something that should recover. It sometimes takes a few weeks, but that should recover fully, and I don't think that it's not a complete facial palsy in any case, and I think that that's not going to be of great importance in her long-term prognosis. We want to, of course, we talked about her ocular movements and looking at the pupils. These pupils are about mid-position, and that's quite normal. We might want to take a look with a flashlight to see whether they react well with light. Well, we can look at that in a minute.
She's waiting.
Okay, well, while we're waiting for that, we can talk about some other tactile reflexes. We talked already about the finger extension reflex with dorsal stroking distally, and we saw that this baby extends her fingers when you stroke her distally. She doesn't continue to flex. The plantar response is tested. She has flexor plantar response, which is normal. If she has extensor responses, though, this is not abnormal unless they're asymmetrical. Asymmetry is abnormal at any age, in premature infants or term infants. But if they can be extensor physiologically at birth, and then they convert postnatally into flexor responses, but they do so symmetrically. That's the important feature. Oh, we do have a little light. I don't know if it's haven't changed. Oh yeah, it works. Haven't changed the battery for a long time. I didn't know if it worked. And okay, that pupil did respond quite well. It's best if you can see both eyes open so you can see the consensual response. This one also reacts quite well, and I think there was a consensual response on the left when I tested the right. Among tactile reflexes, another one that's a good one to do is the galant response, and I can't do this in this baby because of her fracture, but what you would do is hold the baby in your hand, prone, face down on her belly, and then you stroke the side of the baby, the abdominal side, and you should get a trunk incurvation towards the side of stroking. And on the other side, it would go the other way. That's another tactile reflex. It's a transitory neonatal reflex that will disappear as maturation occurs. You can get a rooting response, another tactile reflex, stroking the side of the face or the cheek, and often the baby will turn to that side because in anticipation of feeding. She may not be too hungry right now, so that usually when they're hungry you get a stronger response that way. Palmamental response sometimes you can get. The other thing is in sensory examination is you can use a tuning fork for two things in a newborn. You can use it to test cold temperature because metal always feels cold. And so if we touch her with this tuning fork, you see how she responds immediately by moving her leg. Actually, she moved both legs. And here the same thing. So we know that she perceives cold temperature. And the other thing you can do is you can put a vibratory stimulus here and see how she reacts to that. Now, there's a different number of ways that they can tell you that they feel that. If they're being fussy, they may stop and alert because they're paying attention to the new stimulus, and that tells you they're perceiving it. Or they may, a little bit older infant may smile a little bit because it sort of tickles and it's a pleasant sensation for them. But you can tell if they feel vibration, even if they can't tell you so verbally. We can also test hearing with the tuning fork, and now she turned her eyes and head towards the side that we were putting the tuning fork. And she did the same thing on this side. So we know that she has hearing in both ears. Doesn't mean the hearing is necessarily normal, that she might not have a hearing loss. I don't see any reason why she should, but nevertheless, it tells you that at least she has some hearing that she perceives and she reacts reflexively to that stimulus. And constantly through the examination, you want to continuously reassess spontaneous movements, spontaneous clonus, postures, asymmetrical postures especially, and see how, and of course the state of alertness is a very important feature. Whether the baby is very lethargic and is aroused only when you're actively stimulating the baby, and as soon as you stop, then the baby lapses back into a sort of a sleep state, or whether the baby, is alert continuously once the baby is awake. Or a baby that's really depressed, you may not be able, even with arousal, with even strong stimuli, it may not be possible to get the child to indicate alertness and an awake state. Another observation that you would want to make, a pathological observation, is if you see, apart from the clonus, if you see abnormal involuntary movements, which can be in the form of seizure activity with rhythmical tonic-clonic jerking, or stiffening of one extremity, as it might be a tonic seizure, or not necessarily though, and it could be just the abnormal tone. And seizure activity is important to observe, and sometimes it's much more subtle than that, with just fluttering of the eyelids or tonic deviation of the eyes and head, extension of the tongue, and that would be one observation. Another observation would be dyskinesias. If the baby has athetotic wreathing movements of the distal extremities, the hands and the feet, or dystonic movements of the shoulders, moving in an abnormal, involuntary way. And actually in premature infants between about 26 and 32 weeks gestation, there's a period in which babies normally have physiological dyskinesias, and then they disappear with maturation of the corpus striatum, mainly of the basal ganglia, and that maturation is synaptogenesis, the synaptic development of connections between the nerve cells within that structure, which is very patchy, and normally in that structure during maturation, and by 32 weeks it's pretty uniform, and the baby no longer has the dyskinesia, so that correlates well with some observations that have been made pathologically. Any other abnormal movements that the baby may make in terms of abnormal respiratory movements would be another feature that you'd want to see. This baby is quite alert, actually, and the eyes are widely open. There's no ptosis. The eyes are looking about, and she's quite content and doesn't appear to be in any distress or irritable. She probably would prefer I left, but and I promise you I will very soon. But this baby seems to be making a good recovery from the insult that she had at birth, from the lack of oxygen or poor perfusion, and but she'll need some long-term follow-up in terms of her neurological maturation and recovery, and that may require also some investigations from time to time, the EEG, for example, because the EEG matures also at a very predictable rate postnatally, and we'd be able to see whether the maturation, electrocerebral maturation, is progressing, and it's a very sensitive test for detecting seizure activity before they actually become clinical seizures. So that, and it's a non-invasive test. There's zero risk to it. So that would be something that we'd be following periodically in this baby. An MRI scan, probably the first, she's had an MRI scan, which is normal, and unless the baby is showing new symptoms or signs, there's probably not a compelling reason to have to repeat that very soon, because it does involve a little bit of risk in terms of sedation, so she doesn't move her head during the test, and and the results come out all blurred. But I don't think that she's probably going to need another MRI anytime very soon, in the next year at least. Whether she'll need it eventually, that may be the case, because there's things you can detect later, such as myelination patterns that are not so evident at birth because they're too immature. So I don't want to rule it out entirely, but right now I don't see that as an immediate need. I think this baby has shown evidence of recovery and not regressing and not losing any aspects of development that were improving and now have deteriorated. Muscle tone is normal. Muscle strength is a little bit difficult to test at this age. We can see her spontaneous movements that are normal, and if she didn't have the fracture, we might stand her up and see if she bears weight on her legs or if she has a stepping reflex. And I don't want to do any of these things because I think that might impair her healing fracture, so I'm not going to do that. But if this were a baby that didn't have the fracture of the arm, that would be one of the other things that we would want to do is to look at stepping reflex and weight bearing, which tells you more about strength than it does about tone. As far as the other cranial nerves you want to look at the tongue to see if there's any atrophy or fasciculations, which she doesn't have. The gag reflex would be important for the 9th and 10th nerve. If she's swallowing well, though, if she's feeding well, she's getting this nasogastric that she's getting?
Yeah, mostly, but she did take 50% already.
Okay, so if she's having some feeding and she's not aspirating or choking on it, then her gag reflex is intact, because she wouldn't be able to swallow adequately if she had an impaired gag reflex. Mm-hmm. She moves her head back and forth quite well. Her sternocleidomastoids are working well. It would be hard to assess the trapezius when her arm is tied down. So I think this examination has a few features that require follow-up, such as the clonus and a lot of things that we can't really test very well for at this age, but we'll be able to test for later much better, including vision, hearing, and other special senses. But I think that this baby is really not encephalopathic at this time.